Mm. And we're starting now.
We'll just wait a couple minutes as people are joining in, but it's good to see the numbers rising, and it's good to have everyone here today. So welcome and thank you for coming. We'll start in a couple seconds to minutes. All right, well, as the numbers, as people keep kind of flooding in and joining, I just want to welcome everyone and thank you all so much for coming and joining us. Good morning, good afternoon, good evening from wherever you are. It's good to be able to have an opportunity to all be together and have a really important conversation today. So my name is Lois Donkwa. I am the co-president for the Academy Health chapter at the Bloomberg School of Public Health. And just a little bit about Academy Health in general. It's an organization that really brings together stakeholders to address current and future needs within the health system to the end of informing health policy and practice, and really ultimately to translate evidence into action. And the Hopkins chapter is really excited to partner today with the African Public Health Network. And I'm happy to be joined by Kene Ezigwe, who is representing.
Hello, everyone. My name is Kene. Thank you, Lois, for that introduction. So I'm the VP of Events and Networking at the African Public Health Network. We are a student-run organization, and our mandate is to serve as a forum for discussion, promotion, and collaboration on public health, as well as advocacy and socioeconomic issues relating to the African continent. We do these kinds of collaboration through events like this, so thank you to the Academy Health for inviting us. And just to let you all know other avenues to follow us, we have our annual conference called Faces of Africa, which will happen the week of March 29th. We're also on several social media platforms, mostly on Instagram and Twitter, if you would like to keep up with us and see what we have going on. So with that said, I look forward to the discussion today. Thank you for the invite.
Great. So just a little bit about what today's event will hold. So we're excited to have a discussion on global health equity and socio-political trends of COVID-19 vaccine dispensation. So we're definitely looking forward to talking about global governance of vaccine distribution, while also touching on distal determinants of health to really explore implications for global health after the pandemic. So just a little bit about the structure for today's event. Dr. Nyan, who we're joined by, will walk through a couple slides about global health and equity within COVID vaccine dispensation and his connection to this work. And then we'll dive into a bit of structured Q&A. And we're hoping to also have some time afterwards for some open Q&A. So you'll definitely be able to enter those, and they'll be, we'll be able to dive into those. And we ask that when you do ask your questions, just so we can know who is in our audience with us, since we're not able to see you. For students, mention what you're studying, and if you're a professional, just mention what your field is and what your background is, so we can really know who's filling our audience. But as I mentioned, we're joined today by Dr. Dougbeh Chris Nyan, and just a little bit about him before he introduces himself. So he is a Liberian medical doctor, biomedical research scientist, social activist, and inventor of the US patented rapid multiplex pathogens diagnostic test, the Nyan test. And he currently serves as the chief medical and scientific officer at Shufflex Biomed, a diagnostic startup company that develops testing kits for infectious diseases. He was trained and has worked as a scientist at the NIH, the University of Pennsylvania School of Medicine, as well as the US FDA. He is the winner of the 2017 African Innovation Special Prize for Social Impact and Lifetime Achievement Award in Science Research in Medicine from the Ward Educational Fund. And additionally, he's had a lot of experience working with different epidemics and pandemics. And in 2014, in the 2014 Ebola epidemic in West Africa, Dr. Nyan testified before the US Congress and really provided a roadmap to ending the Ebola outbreak, as well as proposed the establishment of the African Center for Diseases Control. And he has published in peer-reviewed scientific journals, including Nature, as well as Clinical Infectious Diseases and the International Journal of Infectious Disease. And last but not least, he's currently active in fighting against the COVID-19 pandemic in the US and Africa. And this is a moment where we would all clap, but because we're not all in the same place, I'll clap and Kene will clap. I'd like to welcome Dr. Dougbeh Chris Nyan.
Thank you very much, Lois, for that introduction. As you say, I will say something about myself, but I think you have said all already. And the only other thing that is probably remaining to be said is that I started my science education at the University of Liberia, College of Science and Technology, and then went on to the University of Berlin, the charity where I was trained as a medical doctor. So I think that completes the summary. And we can begin, if I can share my screen. Just hold on. Okay. Good afternoon, good evening, wherever you are on the globe. Thank you again for this invitation from the Public Health Institute of the Johns Hopkins University, the Academic Health and the African Public Health Network. I'm glad to be here and share with you some perspectives relating to this topic, global health equity and the socio-political trends of COVID-19 vaccine dispensation. The topic itself says it all, but dispensation comes in various forms, particularly in two forms, either as a matter of distribution or as a matter of an era. So COVID vaccine era or COVID vaccine dispensation, I think both fit this particular situation because we're now in COVID vaccine era and we are distributing COVID vaccine. The coronavirus itself, as you will note, is the family coronavirus. It is a novel coronavirus called SARS-CoV-2, and it was designated as COVID-19 as the disease it causes. That designation was made by the World Health Organization. It is a positive sense single-stranded RNA virus. For those of you who are into the deeper molecular sciences, we hope to go through just a little bit of this. And it is similar to other COVID viruses such as SARS-CoV-1 and MERS, two of which caused some epidemic in the past, about 15, 20 years ago. They have similar structure. If you look at the structural arrangement of the SARS-CoV-2, it has a 5' and 3' region, and with the two open reading frames, and then it has the non-structural protein, which are used for various purposes. Let us go straight to the comparison. They are phylogenetically related, these three, and they have a sequence identity with SARS-CoV-2 up to about 80 to 85%, particularly SARS-CoV-1 and SARS-CoV-2 have a sequence identity of about 80 to 85%, and a difference of about 15 to 20%. And this is very interesting in terms of diagnostic and therapeutic as well as vaccine implications. We're very much interested in the pathogenesis, the life cycle, but particularly so as it relates to the entry point and how we are infected as hosts. Particularly of interest are the spike protein, which binds with the ACE2 receptors, through which this particular virus enters the cell. Once it enters, it then replicates, it goes through the translation, it assembles itself, and then it goes out of the cell through exocytosis, and then begin to infect other cells. These particular ACE2 receptors are numerous in the lungs, along the respiratory tract, but they are much more of numerous amounts in the lungs. And that is why with the symptoms that SARS-CoV-2 causes, which ranges from fever to lack of taste, lack of smell, and then to labored breathing, we have that situation of the breathing difficulties and respiratory difficulties that ultimately, if not taken care of, could lead to death. Here we see that this infection has spread quite wide. It started somewhere in November 2019 in Wuhan, China, and quickly, within about 3 months, it has spread to Europe and the American continent. And later in February, it hit the African continent. During this time, throughout this period, up to this present time, we have had a series of mutations that this virus has undergone. And in South Africa, what we have been hearing of lately in terms of mutation, we have the B1351 variant in South Africa. We have the B117 which originated from the United Kingdom, and the Brazilian variant, which is the P1. This particular thing is very important as the variants are of particular importance since vaccines have been produced now, and our attempt is to vaccinate a good number, at least 80 to 85% of the world population, meaning also 80 to 85% of our national population, so as to create this herd immunity. But with these variants, they pose some sort of a significant challenge to the vaccines that are being developed. But these vaccines have been tested, and we will discuss that later as it relates to this. If you look at the present trend, you'll see that globally we have 117 million confirmed cases and about almost 3,000 deaths globally. The United States alone accounts for about 29 million cases with 500,000 plus deaths. And if you look at the African continent, let us look at the African continent where the virus has been less pervasive. We have about 3 million confirmed cases and about 100,000 deaths. Asia has 21 million. The American continent has 51 million, and Europe 37 million. So you can see how less affected this virus has pervaded the African continent. Why? There have been various reasons propounded: because of the youthful population, one, because of the experience of Africans in dealing with epidemics. I mean, in Africa, there have been numerous epidemics, particularly the latest, which was the Ebola virus epidemic that took place in 2014 in West Africa. So experiences from that, as well as other epidemics that are taking place on the continent, in the DRC, for example, this experience have been brought into fighting the COVID pandemic, although not without challenges, as all continents have had their own challenges. Now, looking at the current trend, you will see a bit of global, not a bit, but a massive global inequality in terms of this COVID era. This has been expressed from time immemorial. In the developed countries, for example, they have high tech and multiple technologies with enormous financial wealth, and they wield a lot of political and economic power. They have solid and well-founded research and medical institutions. That's not the case with the developing countries, which are the low to middle income countries, if you want to use the economic terminology. They're limited technical capacity, and they lack financial resources. I put lack in parentheses because that could be relative. They're weak medical and research systems. They're limited biotech infrastructure, limited testing capacities, as we have been hearing over and over. Although one may want to argue that in the West, there have been issues with testing kits and all of that, but Africa has had enormous issues since it does not produce these kits itself and has to source them from outside. And I speak mainly of Africa because our experiences are from there, but Africa is being used in this case to represent the situation in the rest of the poor or the other continents that contains these low to medium income countries. And there's a limited, political will also, and there's the unused economic potential that Africa has. There are reasons regarding that, ranging far from the colonial period. And so when you look at the enormity of the situation Africa is faced with in this COVID-19 era, just as the COVID hit and has devastated many economies, you will see that Africa and the rest of the low and middle income countries on other continents have taken a harder hit. And this is the IMF World Bank graph, which shows, if you look at the arrow here at in 2019, where the virus started, up to present time, you see how the total debt have increased throughout the time. This represents government debt increase, and this represents private debt increase. So if you look on the graph 2, you will also see the total output. You also see the percent increase in the total debt, just as you have the output, the growth output is decreasing. So you have a decrease in GDP on these continents, whereby the debt burden continue to increase. That's what we want to really say here. Now, looking at Africa specifically, just as Asia and the Middle East, you will see that Africa holds more than 417 billion total debt. And this debt is owned to the IMF, World Bank, and the Paris Club, etc. That's about 36.6% they own Africa's debt. 32% of this debt is owned to bilateral creditors, and about 32% is also owned to private lenders. Now, in this period of time, whereby, as you saw in the previous graph, that GDP is declining and debt is increasing, African governments came together through their finance ministers to request $100 billion in order to use this to fight back the COVID and to settle some of their debt and among other fiscal application that they wanted to use. Now, as all of that is occurring, the world did focus also on then fighting the pandemic. It is in the midst of all of this debt crisis, economic crisis, which have expressed themselves in inequalities in the various communities and among countries. Technology institutions, biotech firms came straight to the fore in order to create therapeutics, to create a vaccine, and to create diagnostic tests. But specifically on a vaccine, we know that in previous times, vaccines would take almost about, say, 10 to 15 years to come out, to be produced. But this time, it took a very swift time to have these vaccines being produced. And this swiftness in time, we will discuss later, has created some sort of skepticism in certain quarters as to why so quick. Well, usually we'll do preclinical trials in animals. That could be in mice, in chimpanzee, monkeys, depending on the system. And then after the preclinical trials, depending on the results achieved from there, we also do then the first clinical trial, which is meant to test the safety of the vaccine. That's here you use about 50 to 100 persons, that's sufficient. The second, it goes to the second clinical trial, again to test the safety, but this time to test what we call the immunogenicity, whether the vaccine is producing some level of protection. Then it goes to the phase 3 trial, which includes then thousands of people, participants. The Johnson & Johnson, Pfizer, and all of these companies did use up to about 40,000, 50,000 persons in these studies. And then given the results from there, these clinical data are then reviewed by independent reviewers, separate from these companies and their entities and the testing sites, and then sent to the various agencies for approval, the FDA or the European Medicine Agency, etc. And then we begin to have that manufacturing. This took place in about 12 months. And that was a milestone, largely due to the amount of technological advancement that we have had over the years. These platforms were already existing, and during this time, they were being put in place. We will note that technology has really advanced over the years. Companies involved in this vaccine production are listed here with their various platforms. We have Pfizer, BioNTech, Moderna, AstraZeneca, Johnson & Johnson, CanSino Bio from China, Gamaleya from Russia, and Soberana from Cuba. Some have the messenger RNA platform. AstraZeneca has the chimpanzee adenovirus platform. Johnson & Johnson, CanSino, and most of them have the adenovirus backbone platform. Some use proteins like Novavax, and others use the inactivated form of the virus. The various doses are listed here, and their efficacy after these trials were determined to be 95% for Pfizer and BioNTech, 94% efficacy for Moderna. AstraZeneca reported 82%. The interesting report here is from Johnson & Johnson, which reported 61, 64, and about 71. These numbers come from the various testing sites, the various countries where their vaccines were tested. You will note that they tested in South Africa, where there's a variant. They also tested in Brazil, where there's a variant. They tested in the United States. So their tests were practically global. And it did speak to the fact that their test was tested during their vaccine was tested on a clinical trial during the time of these variants. So these numbers, people try to play around these numbers and question them, but they are very good numbers and they serve for a very good purpose. Interesting here also is the Gamaleya vaccine, which is the Sputnik 5, which were tested, which were produced in Russia. And we will discuss that also in a little bit detail. Then the Cubans also in South America are also producing a vaccine. We have not received any data on those. As you know, Cuba has been considered as the world medical power for a very long time. They have a good doctor to patient ratio. And they've been very, very good in terms of how their medical system have been set up, but have been constrained due to the long-term blockade by the US. And so they put up their own technologies and try to do the best they can. They produced the meningitis B vaccine. They were the first, I believe, to produce the meningitis B vaccine. And they utilized all of their skills in order to have come up with this new vaccine, and they are testing it. according to the reports, it is producing very good results. In the face of this time, of course, we see again, we turn back to the global debt burden. There is a need for vaccines to be ordered and distributed around the world. These vaccines are being produced in the rich countries. These are high-income countries: United Kingdom, Britain, the United States, United Kingdom, Britain, the United States, and other advanced countries. Now, if you look at the total population and the doses ordered as well as the doses administered, you will see that the United States alone had already ordered about 328 million at the time of the preparation of this slide, and that probably have gone that probably must have increased by now. The UK alone, with 340 million people, have ordered almost 66 million initially. And the next slide will tell you more. Canada, with a population of 80 million, has ordered 37 million doses. And Germany, with 100 million, have already ordered 83 million doses. But look at Africa. And as I said, Africa being used as a representation of the rest of the other continents that are lagging behind. Look at Africa, with 1.3 billion people, had initially nowhere, no means of ordering. But that order of the 2 million doses was facilitated through a process, called the Vaccine Alliance, through Gavi and COVAX. In this, you have Gavi, COVAX, with the WHO and UNICEF, USAID, forming a pool of donors and advocate platform whereby they secure, vaccine through money that is donated or the donation from the rich company themselves. And this pool of vaccine is then distributed to countries that cannot afford to buy them at higher prices, or countries that have some little bit of money to buy can then go into this pool and buy them. So if you look at the European Union, let's look at continental unions. The European Union ordered about 360 million doses. And the European Union has about 1.6, the European Union population is about 360 million, and they order about 1.6 billion. And Africa, the African Union, which has about 1.3 billion population, was only able to secure through certain arrangement just recently through the African Union to secure only 270 million doses. So you can see the disparity playing out here. Now, like I said, on this slide, you see the UK initially ordered 66 million, but in the next slide, they've ordered from AstraZeneca 100 million. They've ordered from this company called Valneva 100 million, and you can see how much they have ordered from all these other companies. Now they placed these orders because they pre-order them, so it is going to be made for them. And once all of that is made, it leaves the orders with not much left, and they will have to wait. The United States have already begun vaccinating. The United Kingdom, Germany, France have already started vaccinating their citizens. But the rest of the world is lagging behind, particularly those countries within the African Union and then the Asian countries. As was stated earlier, Gavi was the one that, through the Gavi Vaccine Alliance, these vaccines were mobilized and have been initially then dispatched to its member countries. There are about 145 to 150 member countries. They initially dispatched about 20 million doses to 20 of those countries found in Africa, Asia, South America, and Europe. Of this amount, they have delivered 14 million already. And they have delivered that, and they hope to deliver to 31 additional countries. Now, what happened here is that this will only be enough to vaccinate about 3.3% of those populations, whereby presently the United States, I think, have already vaccinated far more than 10% of its population, and is trying to shoot for that 70% mark and more in order to create this herd immunity so as to begin to stop this pandemic. The first Gavi doses arrived in Ghana and Cote d'Ivoire in West Africa, and they have been administered already. The picture on the left, on your left here of the screen, you will see the Ghanaian president, Akufo-Addo, being the first person to take this vaccine on the African continent, according to the reports. And so you can see that this has created quite a stir within the scientific medical communities, because if we are to stop this virus, we must do it on an equitable basis. It must be stopped in the United States, it must be stopped in Europe, in Asia, so that we break the chain of transmission, in addition to all of the other public health measures, just as wearing masks, social distancing, and hands washing that have been put in place. That include also the contact tracing and massive, testing in order to detect where any other virus outbreak may be. So you will see that while this is going on, there is a problem also with those who are receiving these vaccines, whether in the West or in the poorer countries. There's a high degree of skepticism and hesitancy. I earlier indicated the speed with which this vaccine was produced. So many persons are saying, why was it produced at this speed when we know vaccines and these medications have always been produced, in 10 to 15 years? Then we look at the ineffective political leadership also in some of the countries, whereby much has not been communicated, with the population. This has also come about in terms of hesitancy because of past unethical studies in minority communities and in places like Africa. In the United States particularly, we'll pay keen attention to the Tuskegee study of the 1930s, whereby syphilitic African males were left untreated. And that created a very big row within the medical scientific community globally, from which then stronger ethical regulations were put in place throughout the years. So these minority communities, particularly so the African American communities, will fall back on that and become hesitant, in taking a vaccine that has been produced so quick a time and which has been advocated against by the leadership in power at the time. And so you have all of these political, geopolitical intricacies playing into this situation. Then you have the anti-vaccine campaigners also. Equally so, in other places, you have corruption and bad governance playing into the hesitancy. Because in countries where you have a huge number of corruption, where they don't believe that the government is saying the truth because the government is corrupt, they're hesitant to take the vaccine because they don't understand whether the vaccine is correct or not. In the first place, in those countries, some of them did not even believe that the COVID-19 pandemic actually does exist. So you have all of these situations playing into this whole vaccine and inequity. Now, as we discuss this, vaccines are being administered as indicated. If you look at this map, for example, the BBC COVID-19 platform gave this very good map. If you look at this map, everywhere that is orange and light yellow, or you may call it yellow, are places on the continent where vaccines are now being administered. And this map was as of February 11 up to the 15th. It must have changed lately due to the recent delivery of vaccines in Africa and parts of Europe through Gavi, but it does not change considerably. You will see the gray area in all of these places. The gray area represent countries on the continents that had yet to receive vaccines. So you can see that almost 200 million have been vaccinated globally in North America, South America, Europe, China, and Russia. But you look at Africa, in particular, and the Middle East, you will see that even less than 5% has been vaccinated to this date. Now, in the same vein, looking at the global inequity, you can look at the national inequity as well. And we took the UK situation to represent that in to represent the situation in the rich countries, like America, for example, where you see whites age 50 to age 50 plus, age 80 plus have 95% of those in the white population have been vaccinated. In the other populations, you see that number is decreased. In the Black population, the Black race, which has suffered immense brutality throughout the ages, 67% have been vaccinated. If you look at the age group 70 to 79, you see the same trend, 94, 78. If you come to the Black population, 64, 50. So what is accounting for this disparity? As we have said earlier, you have the situation of the hesitancy with all of the factors justifying those hesitancy, and others, ingrained racial discrimination and practices that have kept this population back for a very long time. And so in the same vein, we've seen also the politicization of the whole pandemic. For example, reference being made to SARS-CoV-2 as the China virus, by the former president of the US, that which again created another racial issue whereby Asians were being targeted. And you can look at those numbers yourself at some point. Then in that same vein, the Chinese then responded by creating a conspiracy theory that this virus originated from the US Army. So you have this, while medical doctors, scientists, epidemiologists are fighting this virus, you have the political interplay that is kind of distracting and is creating, or was creating, a lot of stir. Then you had the United States withdrawing from the world premier health organization, which is the World Health Organization. That decision made by the former US president. Then you also have this campaign against public health regulations, campaign against wearing masks, against social distancing, physical distancing, and then the lockdown. So all of this had a whole lot to play in our situation. And then you can see the difference in the adherence to these health regulations, particularly in the US, where you see in red, quote unquote, red states, they go against mask wearing, they go against social distancing, and in quote unquote blue states, you have people adhering practically to these regulations. So the internal politics express itself also into the geopolitical politics, that geopolitical arena that have also hampered the fight in this virus. Now, there were also, we saw the political interference in public health response, specifically, where there was the political meddling in the CDC and the NIH work in the US. You had unscientific promotion of chloroquine and hydroxychloroquine, for COVID-19, which were very unscientific. You have promotion of untested herbal concussion by the Madagascar president, where he said that there was this concussion discovered that could cure COVID-19. It was never tested, no scientific data. So you have not only this interference from politicians and leaders in the Western countries, but you also have similar situation in the very poor countries that we are talking about. So it complicated the work of the public health response. And then you have the denial of the Tanzania president, Magufuli, that COVID-19 pandemic, if he exists, he denied it and effectively fought against it. As the reports have it, it has to be verified that he came down with COVID-19 and had to be transported for medical treatment outside of Tanzania. And you have displacement of public health. You have displacement of public health expertise in Liberia, for example, where the incident management system was composed and comprised of some non-public health expertise to head the incident management system, the actual public health professional or Harvard graduate, Dr. Fowler, was removed for no apparent reason. And so you have the fight against COVID-19 pandemic taking a completely different situation in Liberia, in the United States, in many countries. Far to that, in terms of the geopolitical interplay, you also have in the process of this vaccine production, some Western countries doubting the Russian Sputnik 5 and the Cuban vaccine production. So, there's the economic side, there's the political side that has then drifted into public health and medical response. So you have them questioning whether, the Sputnik 5 is good, it's not good. And of course, you have others praising the vaccines from the West, from Pfizer Biotech, from AstraZeneca, et cetera, et cetera. Then you had doubt about the Cuban vaccine also, for which led the Cubans to then collaborate with the Iranians. Now, mind you, the Cubans and the Iranians are two countries that have US blockade. And so they don't have much of a collaboration from Western countries, as the Western countries are collaborating with each other. So they then say, well, let us pair up and utilize the little technology that we have. Then there was question about India's manufacturing capability. Later, they show that India had a very good capability in manufacturing. Some of the vaccines from AstraZeneca, in fact, are being manufactured in India to this date. Then there were questions about the South African trials also. So in this, what we have opted for is collaboration, and that's what we are seeing now. There's now the vaccine production collaboration between AstraZeneca and a Korean firm and an Indian firm. We also see Johnson & Johnson collaborating with one of their heaviest competitors, Merck, for the production and mass production of the vaccine. We're looking at technological transfer also that has been proposed. And as we stated earlier, Cuba and Iran have then collaborated in producing vaccines. And Gavi, which is, this platform for mobilizing vaccines for poorer countries, have also then done a lot in mobilizing vaccines so that poorer countries can be served. I will, at this point, like to propose the following recommendations. There must have to be, hold on. Before I go to those recommendations, I just wanted to indicate to you that as we talk about the COVID-19 vaccine and production of kits for diagnostics, there are efforts on the African continent. Although the technologies, the continent is not so technologically advanced, but there are efforts on the African continent aimed at producing diagnostic kits, and that which could also lead to these technologies transforming into producing vaccines themselves. We have Shufflex Biomed, from which I come, that has a rapid multiplex diagnostic test that can detect anywhere from 3 to 7 infectious diseases, including the few that are listed here, the COVIDs and Ebola, HIV, HCV, in a short span of time. We have Incas Diagnostics in Ghana, which has produced, this rapid diagnostic test for COVID-19. And only if these companies can have, or this startup can have the necessary collaboration to produce these test kits in mass, and then use their technologies also, diagnostic technologies, and then their other capabilities in terms of therapeutic and vaccine technology to also produce vaccines, it will have gone a long way. And so that brings me to these recommendations. There's a need for technology transfer, and not the continent simply being used as a dumping ground, for all medical equipment or as an area for extraction of research data only. That's what most think that the continent should be good for. There are very well-trained scientists on the continent who can carry out equal scientific innovations that will lead to products. We want supportive collaborative research. There also should be, at this point, I would definitely call for debt cancellation. As we have seen, the countries are heavily indebted, and they have been indebted from the time of colonialism. All of the former French colonies, for example, in effect, are still paying France for their freedom, up to a tune of 80 to 100 billion dollars a year from money that they invest into some coffers in France. You can Google those and you can do the research, and economists on this platform in this meeting can verify that. And so there needs to be a debt cancellation so that after this pandemic is over, the countries can reset themselves. But in the process of that debt cancellation, there should also be measures put in place so that actual accountability and transparency can be displayed by these governments on those continents, in those low to income countries, particularly those that have been already known to be corrupt. We have to then address the racial and ethnic inequalities in the various communities, be it in the poorer countries or in the rich countries. The disparity between whites, Caucasian, African Americans, Asians, people of Latino background, and in the African countries, the disparity between the hyper-rich and the very poor, the disadvantaged, et cetera, et cetera. There needs to be community vaccine educational campaign in order to fight against this vaccine hesitancy. And in this sense, enormous vaccine centers need to be established, not only in the West as we are doing, but also in the various countries. But what are these countries, given the fact that vaccines have now been mobilized and transported there, are even prepared to carry out this massive vaccination in the history of the world is yet to be seen. And so there will be a need to provide logistics like transportation, PPE, and storage facilities, because in most of these low to medium income countries that are in the tropical regions, they may not be able to handle a Pfizer biotech vaccine so easily, which require a very deep freezing, up to minus, that require minus 70 freezers, for example. So these kind of logistics need to be provided. The Johnson & Johnson vaccine, which does not require that much of a storage, can be an option. But as these other vaccines that require this, delicate handling have been shipped to the African continent and the Asian continent, this needs to be taken into consideration. There needs to be an increase in testing as well as contact tracing still. And as we will note, while we talk about the vaccines will do what they can, but equally so, we still need to get vaccinated. People need to get vaccinated. In the United States, in Europe, everywhere, whoever is listening, my call to you is get vaccinated. All of us scientists, medical doctors, epidemiologists will not just conspire to come and do harm to the world. I mean, people take sleepless nights to stay in the laboratory to find out what is effective that can, cure diseases and cure viruses. People take sleepless nights to put together data to see where these interventions need to be carried out as epidemiologists and public health professionals, public health students, etc. We still need to wear our masks. We still need to physical distance, and there's hand washing. Those basic public health regulations have helped a lot. And I will end at this point and we'll turn this thing over to you.
Wonderful. Thank you so much, Dr. Nyan. So I'd like to, the presentation was so wonderful, and it was just so wonderfully full and answered most of the questions that I had and that I was really curious about. So thank you so much for such a strong and robust presentation and walking us through really the genesis of COVID-19 so that we could understand it on the physiological level, but then also walking really into the political and policy realm to really understand that and those implications as well. So I still do, Kenny and I still do have some questions for you, but I'd also like to share with our attendees that if you do have any burning questions, please certainly share, type that in the chat, please. And while we're kind of talking through and discussing, we'll get to yours hopefully as well. But so my question is, you mentioned, I loved the slides that you had where you compared developed and developing countries in terms of the kind of different strengths that they had and really areas of growth for both of them. And then you also, in another slide, pinpointed out the amount of kind of vaccine count for each for countries, and then also highlighted how much they had received. So I'm curious, like just when you think about the barriers that have been cited for lack of vaccine rollout in low and middle income countries, a lot of times what you see is a lack of, or what's described as a lack of infrastructure necessary to store the vaccine. So while you did mention recommendations and you highlighted that you're in a diagnostic group, and then also in Ghana, they are really strengthening their ability to test. Could you speak to vaccine distribution in particular and how preparation is being made on the ground to really prepare for vaccine distribution in terms of logistics, infrastructure, and prioritization in low and middle income countries?
Thank you. Quite frankly, epidemics usually catch everybody unaware. Nobody anticipated an epidemic. And so most of the countries were actually unprepared. But looking at the lack of good infrastructure in these low to middle income countries, it poses much more of a graver challenge because over the years, these countries have had very dilapidated broken healthcare systems. Take West Africa, for example, that was hit with the Ebola outbreak about 5 years ago, 2014 to 15. It definitely showcased the weaknesses in the health systems in those countries. And while they were recovering, you have the COVID-19 pandemic as well. So there is a lot that is needed in terms of logistical supply, in terms of the logistics. So these countries are preparing, but they are not preparing at the same pace, or they are not prepared at the same level as the Western countries are prepared. The Western countries produce these, equipment and the PPEs and all of these things. Even if they did lack them in the initial stages, they have the manufacturing capability to just produce them en masse. There was a call in the United States for some military act to be evoked that would make the factories, producing like they did during the World War. And so I think Biden is pretty close to doing that, if that is the case. But in the poorer countries, you don't have any factories in the first place to even evoke an act for production of anything, So that is where you have the disparity, which is clear and leaves these countries unprepared. The director of the Africa CDC, Dr. John Gasson, also alluded to this, that there are challenges.
Thank you so much. So we'd like to jump to provide room for our audience to ask. I see it's very active. So I'd like to welcome the VP of Communications in the Academy Health Chapter, Shruti Sinkar, to join us and talk through those.
Hello, everyone. So I'll just get to reading the questions. We have a question by Andrew. I'll read it out. What are your thoughts on some countries introducing digital coronavirus passports, which is basically like a documentation proving that you have been vaccinated? And what are the equity considerations with that kind of documentation?
Well, from a public health standpoint, it is something that is welcome. It's not new. Why? Because people have been traveling with medical, if I can just say medical or vaccination passports for years. I mean, so this is not new. For those of us from, Asian, African countries, even from the United States, you have what you call the yellow book, where they stamp all of your vaccination regimen, your MMRs, your hepatitis B, and particularly if you go into Africa or Asia, you must have, according to the regulations, your typhoid and yellow fever vaccination. So we've had this, for years. It's unfortunate that in the Western countries, most of the population are not aware of this kind of situation. And so it becomes an argument, it becomes a kind of how can I put it? It becomes a political tool, that people will want to play with in terms of privacy and, other things. But this is public health, and I definitely do support that. It's been existing, it's not new.
Thank you for answering that question. The second question is, which vaccines are currently under order for Africa continent, specifically the 270 million doses currently that are placed under order?
According to the Gavi list and according to the reports from Gavi themselves, they've ordered some vaccines from AstraZeneca, I believe, Oxford AstraZeneca, and they hope to order Johnson & Johnson because that will be much easier, relatively, comparatively easier to handle, since it may just require the regular refrigeration. So that's so much that I know about the type of vaccines that have been ordered.
Thank you. The next question we have is, African countries are heterogeneous. Do you think it would be more strategic to prioritize investment for joint research in so-called regional hub countries such as South Africa, Ghana, Senegal, Kenya, and let them support their neighboring countries in long term?
Certainly, the African countries, yes, there's this heterogeneity, but there is a commonality also. The African continent have a common colonial history. They have a common history with fighting against colonialism for liberation and all of that. Through that process, they have had this luxury of collaborating with each other during the fight against colonialism. So the essence of collaboration should not be anything new. When the remaining of Africa was still colonized, South Africa, Namibia, the whole of Africa put together and fought against, the last vestiges of colonialism. I think these political fights and these can be translated into economic cooperation and then medical cooperation, for which some time ago, I proposed that there be an African medical corps to be formed that can mount, a response on any continent, any continent or on the continent in case there's an outbreak in any part of the continent. So equally so, we have been proposing collaboration in research. So Africa is very good, in terms of relatively good in terms of infrastructure. Nigeria is also coming up. Ghana is right there. Kenya is also doing a lot. But if we can harness all of these and also support them by national resources, if the GDP of these countries can be increased into supporting science, medicine, and research, I think we will not really be calling for Western aid every time. one of the major things also from an advocate point of view is the depth of corruption on the continent in these individual countries. It kills innovation, it kills growth, even the economy, it kills the economy. In recent times, you have money being recovered from Nigerians past what you call it, governors, in a tune of 3 million euros. Do you know how much 3 million euros can do? Which is almost about $5 million. You know how much that can do in supporting these 2 diagnostic tests that we just put up and then being translated into producing vaccines just for the continent. And that's where much of the problem is. It's not that there is no corruption in the West, but it is stamped on, and the systems are there to keep a check on corruption. In our part of the world, corruption takes a few days, and people are even glorified when they, when they corrupt, they are put to jail, come out of jail, they are glorified. So we need to look at that. For you who asked this question, those are elements that we need to look at. We can collaborate. The resources need to be utilized properly. Corruption has to be stopped. And we have to believe in our own innovations, our own technical capability.
Thank you so much, Dr. Nyan. This was a wonderful discussion, very insightful. I want to be mindful of everybody's time. I see it's already past 4 o'clock on the East Coast. So I just want to say thank you all for attending. Thank you for the wonderful conversation and the insights that you presented to us today. And yeah, thank you to everybody who was working behind the scenes to bring this, make this webinar a possibility. And thank you all for attending. Yeah, thank you all. Have a great weekend.
Thank you very much. I appreciate the invitation, and we'll be talking again.
Yes, definitely. Curry, you can stop recording.